epidemiologist, we don't swim in the same pools. So I go to a lot of epidemiology meetings and talk about my addiction research, but it's really epidemiology related, and the people have big conferences and talk about more the neuroscience part of things. So we need to, communicate better. And this is a small opportunity to do that, I suppose. So what I'd like to talk a little bit about is the case of the downtown east side of Vancouver, which is within about a 20-minute drive from this particular conference venue for those who are visiting. And it's our really little microcosm of problem drug abuse, maybe in Canada, and one of the largest congregations of injection drug users in North America in a very small area. I want to touch on failure of current policies to reduce illicit drug use, reducing the harms associated with illicit drug use, so our work in harm reduction, and possible alternative approaches. The context of Vancouver's downtown east side is it's an extremely poor area. In postal code language, it's the poorest postal code in Canada. There's very high rates of HIV and hepatitis C infection, and the studies that we've been involved in, and I'll show you a little bit, but probably the overall prevalence, about 25 to 30% of people are already HIV positive. There's a lot of drug overdoses, and this tends to fluctuate over the last decade, but at one point there was an average of an overdose death a day in this community. Now it's down to maybe between 1 and 200 per year. There's literally thousands of injection-related infections resulting in ER visits and a lot of hospital admissions. For 3 months of the year, I work as a clinician in infectious diseases at St. Paul's Hospital, which is a major catchment area of this. And at any one time, there's about 60 people in hospital with infections directly related to needle use. And of course, injuries due to accidents and violence associated with drug use, and a huge, large open drug scene, which takes a lot of public attention. So people are very concerned, especially with the 2010 Olympics coming, that this is an unacceptable thing for a major city to have people hanging out on the streets and alleys using crack cocaine and using needles. So it's a huge focus of media attention, both in British Columbia and Canada. This is a small map of it. It's not really to scale, but really it's only about 10 square blocks of territory where people live, and it borders along the ocean, which is all really where a lot of older ports were established in the Vancouver area. This is a common scene, so there's a lot of warehouses there, so it's really out of a New York City cop movie or TV show where there's just miles and miles of alleys with dumpsters and people hanging out around them using drugs. People generally live in very poor living circumstances, and these are some of the more notorious hotels, but we call them SROs, or single room occupancy hotels. People live there by the month, and there's perhaps about 4,000 of these units in this area, and that's the primary housing for people, although there's a lot of movement. Gabor Mate is actually in the audience today, and he works in one of the serviced hotels called the Portland, and he has a lot of work with this. So there is a real emphasis to try to use these hotels as they exist, but actually provide some services, and Portland is an example where that's happened. People in the audience will clearly know there's a lot of societal consequences of this. In addition to the health consequences, it's really created a large underclass of people who can't seem to leave. There's destruction of relationships and families and friends, so there's a lot of very isolated people there in spite of the very dense housing arrangements. Public drug use reflects very poorly on the city, as I've already said. There's a lot of fixation by the public about theft and violence to city residents, which is probably overplayed in the media. The costs associated with policing and enforcement are overwhelming. The costs associated with legal, court, and prisons are overwhelming, and the health costs are overwhelming. And as we talk theoretically about addictions, and it's a very fascinating conversation to have, but we have to have to realize that 95% of the money that our government spends on addiction is enforcement. So we generally wait until people are in a position where they're starting to have criminal behavior, and then we put them in prison. So that's where our major government focus of addiction stands in Canada, at least, and certainly to the neighbors in the South, that enforcement is what's really driving addiction, and people really don't think about these bigger issues about why this might actually be happening to people. HIV rates have really brought the Downtown Eastside into focus, and this is 2001, 2002, 2003 data looking at deaths due to HIV, and the big bars where it says DTES, or Downtown Eastside, the rate of HIV infections are 40 times what they are in the province of BC alone. So this is a highly congested area as far as HIV infection goes, and we've tried to monitor incidence, and even though we're instituting a lot of harm reduction practices down there, the prevalence is so high that it really drives the incidence of new infections, and it's very difficult now to really slow down the number of new infections that are happening no matter what we do. So if you share a needle with somebody in a community where 1% of people are HIV positive, you can do that 99 times before you'll be exposed to HIV. If you do that in a community where 30% of people are HIV infected, you do it 3 times and you'll be exposed to HIV. So you can see that once you allow a community to get this much HIV endemicity, it's very difficult now to slow this down. Hepatitis C is 95%, so we have a community that's essentially saturated with hepatitis C. And this is our best estimates of the prevalence, and really amongst injection drug users, the HIV epidemic didn't really start till the early 1990s, as opposed to the epidemic in the gay community, and you can see a very steep rise over the last decade, and we're left with about a 25 to 30% prevalence. We also have major problems in this community with treatment of HIV. So as people would know, we have really life-saving, fairly effective, durable, well-tolerated medications for people, but we still have a lot of trouble engaging people with active addictions in any kind of medical care, including HIV treatment. And this is one study we did linking with the vital statistics for the province, and still about 40% of people who died of HIV in British Columbia never received antiretroviral treatment. And this is heavily congregated in communities where there's a lot of addiction driving this, where we really seem to be quite helpless in trying to engage people in long-term treatment. Vancouver is also notorious for our murdered and missing women. So there's 60 to 65 women who have disappeared, found a lot of their remains on a particular farm just outside of Vancouver. This is going to become hugely political in the coming year because the trial is just about to begin. So they've spent the last 2 years collecting all this forensic data. Ironically, I don't know what the final bill, but it'll be in the multiple millions of dollars digging the remains up of these women from the farms. And although people certainly need some kind of closure for this, it seems quite ridiculous that we're spending so much money cleaning up the mess, and then there's probably another 60 women sitting out there tonight on the street that the same fate could easily happen to them. So our focus is really after the fact, just like our focus on addiction is really after the fact, after people are so far entrenched into their street work and their criminal behavior, they just have no options but to go to jail. And so again, for women who are involved in the sex trade, the same thing happens. We're barely focused on them now that they're dead and missing, but we're very slow to put in any services and make things better for people who are out there right now. Should keep moving, I hope. Time's ticking, I know. There we go. Certainly one of the substances that's really pushing this is cocaine. So we've done quite a lot of studies amongst cocaine in this community. It's really been central to the HIV outbreak, and it often results in fairly erratic drug use behavior. People use it in a high-intensity fashion. That greatly impairs decisions regarding safe needle use and other harm reduction interventions. So people into their 10th or 20th or 30th fix that day, no matter how well educated and how well aware they are of the risks of sharing needles, for example, they're usually not in good shape to make those decisions. And really, we're stuck with very little in the way of tools to manage cocaine. So people in the audience would have a lot of more insight into this possibly. But as far as how we treat people with cocaine addictions, we are trying to increase the number of detox beds, but this is a very short-term, very unsubstantiated intervention for these people. They'll be in a detox bed for 5, 6, 7 days, and then they wouldn't have used during that time, and then they're released right back into the same environment, and it's just this horrible cycle over and over again. And unlike heroin addiction, we really don't have any good substitution therapy for this, or really any interventions that have shown to be very effective. And this, I think, is a very high priority area. I do some work in Eastern European countries and Asia, and again, methamphetamine and cocaine are really what's driving it. It's not so much the opiate addiction. And again, we're really, as trying to come up with interventions for cocaine is extremely important, and there's a real lack of interest or interventions to deal with this. This is just showing one of the studies we were looking at in this community, looking at how important it is for cocaine and HIV. So this is really the intensity of cocaine use. So if you use people at the baseline who use cocaine less than 1 time per month and compare them to those who are using an average of 3 times a day, the 3 times a day people are almost 8 times as likely to be HIV positive, so controlling for many other variables. So it's really, again, just illustrating that cocaine is really a problem in driving the HIV epidemic. People aren't crazy. They don't really want to get HIV. Needle use is still is probably more frowned upon than it used to be, and so crack cocaine has now become the route of cocaine ingestion that's preferred by many people. Communities like New York City, for instance, needle use is down dramatically, and crack cocaine, where we seem to be in Vancouver, maybe 6 to 8 years behind the epidemic in New York, for instance, and I can see in the coming years that needle use will become less common, but crack cocaine will be the drug of choice for people. And although from an HIV and hepatitis C perspective, this may be somewhat less risky, there's still a lot of problems that go along with crack cocaine. We can't forget alcohol use, and again, in this community, there's a lot of polysubstance use, and alcohol is part of the problem drug use for a lot of people. And this particular patient of mine who drinks 2 to 3 bottles of rubbing alcohol a day. So this is really low-level alcohol addiction that people are I guess you'd call it high-level alcohol addiction when people are drinking rubbing alcohol. So this is, serious problems for people. Actually, just as an aside, this particular patient of mine is probably the most adherent to HIV medications that of any of my patients. He's got an undetectable viral load and a normal CD4 count, and he hasn't missed a dose of his HIV medications for 3 years. Every day he comes in and gets it, and usually he's smelling of his rubbing alcohol, but he's managed to keep his HIV under control. So what are we generally doing with this? So conventional strategies, and I speak in Canada, but we are more and more influenced by Americans, that we really, the conventional strategies are to educate people about the risks of drug use, to criminalize drug production in an attempt to limit supply, to criminalize drug use in an effort to limit behavior, and most importantly, instill this belief that this works well and discredit alternative approaches. So as these approaches continue to fail, more and more emphasis is put on these failing interventions. And I guess this can be roughly called the war on drugs. So this is our war on drug approach that's been quite an abysmal failure in North America. As far as our educational programs, we have our multimedia campaigns, our Just Say No and Dare, which cost millions and millions of dollars with no evaluation and no apparent, for all intents and purposes, no evidence that it has much impact at all. In British Columbia, most of the drug education in schools where we want to reach people are done by police. So in some ways, this seems totally ludicrous that you send police officers who are paid to enforce drugs to try and educate students about drugs. And parents telling their kids, and we know the data for that, it's not particularly impressive. I work with drug users every day, and I often have difficulty trying to tell my kids about drugs. So, I mean, it's leaving it up to the parents is not 45 minutes? Oh, great. Okay. Leaving it up to kids. So this kind of educational campaign, the way we're doing it, in multimedia especially, it's mostly hysterical data. In BC, it's crystal methamphetamine now is really taken over as far as the press go. This is a plague that's sweeping across our high schools and killing all our kids. And these kind of messages are not really believable to anybody, including the kids that are supposed to be scared about this. So we're not giving very clear messages or very accurate information about drugs. So I think we can do a lot better on our educational programs. As far as our interception of drugs coming into Canada, we're doing a pretty poor job of that, although we get a lot of publicity. So this is the Great Vancouver Seizure of 2000. In September 2000, Canadian law enforcement officials achieved what was stated to be the largest heroin seizure in Canadian history. 100 kilograms of uncut heroin was found. Try and put this in perspective, the sum total of heroin seized by U.S. Customs along the entire southern border during that same year was only 113 kilos. So this was a huge, huge drug bust. We have some large cohorts that we follow prospectively in the community, and this was the impact right around this big bust, which was reportedly going to get heroin off the street. In our particular in our particular cohort, before and after the seizure, there was a little increase in heroin use. There was no change in people getting on methadone, and there was a little blip in non-fatal overdoses, but otherwise unchanged. So the media would say this was the biggest thing that ever happened to Canada. Our heroin problem is over because we found the source, and really on the street it made absolutely no difference. And actually the other data we collected there, right after the seizure, the price of heroin actually went down, not up. So it's this heroin they found probably had nothing to do with the Vancouver market. It was probably meant for somewhere else. And so, but the police use this as a way to justify more and more money to intercept drugs. And the publicity they got did increase the budget to the RCMP to get more helicopters and more people at the border to try and intercept drugs. This is another way of enforcement that's been a dismal failure. I picked this picture because there's famous Maine and Hastings where it was a huge open drug market. And this is a picture when the police came out and said, well, they're going to clean up that part. And so they parked a couple of police cars right there. And what do you know? Everybody left. So there's no evidence that one person stopped using drugs or that anything changed, but just by parking a couple of police cars there, people will go to the next alley, and then they move the cars, and then everybody comes back again. So, this is supposed to be a big an example of how enforcement works. Just where the white police car there, that's called the Health Contact Center, and that was created to be a very low threshold environment where people who are having crisis, who didn't get to clinics or other places, could be taken where there'd just be supports. And so this very low threshold environment, when you park a police car in front of it, just isn't as attractive as it was meant to be. So again, working with police can be quite challenging. This whole prohibition causes a lot of unintended consequences. We know both locally and globally that prohibition increases drug production. It actually decreases prices. It increases drug purity because people don't want to carry bulky drugs around. It increased organized crime, and there's very high rates of incarceration. And there's tragic data. I use American data because it's so much grander, but 2 million Americans are currently incarcerated, 75% for non-violent drug offenders, and many of them are black men. So this has a huge implications for our society, taking people with non-violent drug crimes and putting them in prison. And just think of the effect it has on families and what the chances of these people with now a criminal record integrating back in society. And there's a lot of push by our government to get people off welfare, get them on work, and a criminal record pretty much limits your opportunities for those kind of things to happen in any kind of productive way. So putting people in jail, this doesn't make any sense at all. Are there alternative approaches? Well, I used compassion in my title, and I would apologize for anybody who studies that kind of compassion, and I use it in a very uneducated, broad sense of the way. But compassion to me is really just trying to accept people where they are and try to reduce harms. And this is this big topic of harm reduction, and that's what I'm now tending to be involved in. So there's no reason to try to discount prevention. I think we should try to educate people and try to prevent people from getting on drugs. And when I talk about the addictions I'm talking about in Downtown Eastside are cocaine and heroin addictions. However, if those don't work out very well, we need to do other things. And engaging people in care and counseling, expanding our needle exchange programs, providing more widespread methadone substitution. But as I said, a lot of people in this community really don't qualify for methadone because opiate addiction is really not what their problem is currently. Support community service organizations. I'll talk a little bit about the supervised injection facility, which again in Vancouver has got a lot of publicity. Expansion of detox beds, develop long-term recovery houses, offer women's programs, and educate the public. And this is just, to me, a very generic list of things that need to happen. But as I say, if you look at the budgetary constraints on all of these kind of programs, it's immense. And the budgetary constraints on enforcement seem to be limitless. So there doesn't seem to be any constraints at all. And we keep on pouring more and more money into these programs or these approaches that have no impact whatsoever. And the worse they perform, the more money they get. And it's just this paradoxical situation that occurs. I'll just spend 2 minutes on the supervised injection site. I'm in charge, or with a colleague of mine, Thomas, in charge of the evaluation of this. So it's North America's first supervised injection facility. People are allowed to inject in a controlled setting. They're given sterile injecting equipment. They're given information on safe injecting practices, which you'd think most people who are injecting all the time would know how to inject safely, but that's not the case. And so there's a very worthwhile interventions that people can show people how to put the needle bevel up or down, those kind of things. There's counseling and primary medical care, and there's a lot of referrals to detox and other services. And since it opened almost 3 years ago, there's been 4,500 people referred to other services. So it's extremely important to engage people who are not getting any regular services. That's what it looks like from the street. There's about 40 or 45 of similar programs in European cities, but I think in Vancouver we have sort of the Cadillac of supervised injection sites. So it's a very nice facility for people. There's 12 units that people can come in and inject in. There's nurses, and they use a lot of peers and staff. It's a pretty welcoming environment for people, and incredibly, you can have 12 people in there injecting all at once, and it's a fairly calm atmosphere. There's been no major problems as far as violence goes. There's been 350 overdoses on site, no deaths. I mean, so it's really served a very important service. We're up to over 500,000 people, 500,000 visits to the site, and about 5,500 different individuals have used the site. And this is maxed out as far as the attendance go, and daily there's about 650 to 700 people that are using the facility, and that's pretty much around, it's only open 18 hours a day. We're trying for 24 hours, but that's pretty much full. That's pretty much at capacity. We also have a big project in survival, around survival sex workers. This is a huge problem, again, as far as HIV transmission. We know that these are the women who are not in any care. From a purely public health perspective, they're very high risk for other people getting HIV, and you have to be very careful with the terminology because we're trying not to marginalize these women and downplay the idea that they're somehow vectors of infection, but at the end of the day, from a public health point of view, there's a lot of infected women having a lot of interaction with people in the community, and they're not on any HIV treatment, so it's a real problem that way. We estimate there's probably 1,000 women who are in that community who sell sex. The social and environmental context of the lives are increased risk for HIV infection through entrenched poverty, a lot of homelessness or poorly housed people, repeated episodes of violence and assault, social isolation, stigma, and their substance abuse. We have a criminalization of sex practices is the way the law is interpreted in Canada, so it's not a crime for prostitution, but it is a crime to communicate for the purpose of sexual exchange, so that all that does is push people to invisible areas. So if you're going to get picked up for communicating with people, then you go to areas where you're not found communicating. And so people are again displaced to places where they're even more vulnerable. There's increased violence, and they're discouraged from reporting bad dates. Just skip over that. So I can understand with the situation at hand why there's opposition to any kind of harm reduction that would try and engage people in addiction treatment and try and reduce their risk of HIV and hepatitis C. One would be a belief that the elimination of illicit drugs from society is possible, and again, that there's quite a lot of history about this, and it's pretty unlikely to be seen in our generation. When you're advocating for harm reduction and working towards making lives better for people with addictions, somehow it's interpreted that we are advocating drug use, and for most of us working down there, we've seen the absolute worst of what drug use does to people, so clearly we're not advocating this as a lifestyle for people, but there's major obstacles to breaking the cycle of addiction. Other people have the belief that drug use is a personal choice. People just have to pay the consequences. So I think as as society goes, I think that is not an uncommon approach to addiction. So people, when they see people in trouble in that community, for instance, it's a blaming the victim, that this is their fault, they brought this upon themselves, and whatever happens to them happens. A belief that harm reduction enables drug users. We've done a lot of studies about this. It's a totally ridiculous concept that somehow there's any kind of attraction from this kind of lifestyle for people, that somehow my kids leaving their nice house would walk to the downtown east side, see people slumped beside a dumpster and think this would be a good thing to do and give me a free needle. So enabling is not what harm reduction does. A belief that harm reduction attracts new drug users. That was my last point, I guess. And a belief that harm reduction services attract drug users from all over the place, so there's a big honeypot effect. And again, that is just not happening. And people, we know from needle exchange programs, for instance, that people won't travel more than 3 or 4 blocks to get their needles. That's why we need to put needle exchange more available to all over the place. So the kind of opposition we hear from from harm reduction, against harm reduction, really have no validity at all, and it really comes down to some moral attitude towards addictions. Reasons for a compassionate approach. Again, I don't want to sound like a social worker because I have no training in that, but this is my clinical sort of approach to things. But Most addictions don't happen by chance. We need to know the context and try compassion. And as we've already heard today, I mean, whether how much is to do with actual chemical brain changes that happen, or how these other things play out. Certainly, people have fairly bad life stories, and that this has to be taken into consideration and not blaming the victim again. Most people, this is my last slide, I'll be right there. Most people with addictions are immune to punishment, as that is all they've ever experienced. So to try to keep punishing people more and more doesn't make any sense to me at all. People with addictions have extremely low self-esteem, need to be built up, not torn down. We need to have a very understanding, compassionate approach to things. To see someone through to recovery takes a long time and requires patience and compassion. So there's no quick fixes to any of this, whether we come up with substitution therapy or not. And this is a long road for people to be on, and we really need to be in it for the long haul, and that takes a lot of understanding and compassion. So that's it. So in summary, I thought Vancouver was a good illustration of really a microcosm of the tragic outcomes of illicit drug use. The drug policies that we currently have largely failed, certainly in this community. And harm reduction approaches must be pursued, but are not sufficient. And a comprehensive, compassion-based, long-term approaches must be pursued.